So welcome to the cardiovascular exam, an introduction here. So we'll just go into the principles of the cardiovascular exam. Now, like all exams, what we need to do is to ensure that we have the nice breadcrumb trail at the top. So begin with a general inspection at the end of bed, general exam, inspect, palpate, percuss, and auscultate. So, beginning, before we do an exam, what do? We do a history. And the cardiology focus history involves taking history as per, but clicking into a series of cardiac questions. Because cardiology is such an important part of internal medicine, we need a good mnemonic for it. Let's use something like cardia, shall we? So C, chest pain. You're going to ask about chest pain. A, ankle swelling, classic sign of heart failure, right? R, racing heart, so palpitations. D, difficulty in breathing. IC, which is intermittent claudication. And then finally, altered level of consciousness. So for the general inspection, what are we thinking about here? Well, we're thinking, okay, is the patient well? Or do they look sick? Do they look really sick? Do we need to do an intervention right now to stabilise that patient? Does the cardiovascular exam need to become an A2E primary survey? Difficulty in breathing, is there any obvious cyanosis? Are they cachectic? What's the BMI going on here? Do they have malar flush? Now here's a beautiful high-def picture of a malar flush, classically seen in mitral stenosis. So, in terms of the medical paraphernalia at the bedside, there's a whole array of things that can be going on here. So, do they have ECG electrodes hooked up to them? So, indicating that someone's already been looking at heart problems. Are they currently on oxygen? How much are they on? What route is it? Is it going nasal specs? Is it a mask? What's going on there? Do they have a trach? Do they have any walking aids so they're at risk of falls? Do they have their glasses on? If they cannot see you, are they communicating as well? Are you getting a good rapport? Those glasses that you have on the table there, patient, are they for reading? No, they're for distance. Do you mind popping them on so that we can have a conversation where you can actually see me? These things make a huge difference. No pillows. Do they need pillows to prop themselves up because there's fluid on the lungs because of heart failure? Position. What position are they in? Are they lying flat? Are they able to tolerate lying flat? Are they desaturating and becoming hypoxic because they're lying flat and they need to sit up? So much information can be gathered right at the end of the bed. That end of bed assessment where we dramatically stand backwards, focus on it. So Down syndrome, Turner syndrome, Marfan syndrome, and ankylosing spondylitis, classic med school finals. All of these patients can get congenital heart disease. So you're looking at the end of bed. If a patient looks like they might have one of these congenital conditions, that leads you to a higher index of suspicion of a pretest probability there's something potentially going on with the heart. Let's move to the general exam. And you think CP, chest pain, well, we can use CP for the hands. So if we begin on the dorsum of the hands, there's 3 C's, and then go into the palmar aspect of the hands, opening the hands up, supinate the hands, and we get the 5 P's. What are the 3 C's? Clubbing. Lovely club nails there. Clot phenomena. Thinking about your infectious endocarditis, we've got splinter hemorrhage there. And then cholesterol. Are there cholesterol deposits on the extensor tendons of the digits? What about the P's? Well, I've taken a liberty with one of these, so puffing away on your cigarettes, that's your tar stains. Pallor of anemia, peripheral cyanosis, speaks for itself. Pressing for capillary refill time, and then pain or painless nodes. What do I mean by that? Well, I mean Osler or Janeway. Osler, think Osler ow, because Osler's nodes hurt. And Janeway, think Jane wave, because they often present painlessly on the palm. So a nice friendly wave. Osler ow, Jane wave. I want you from now on to say Osler ow nodes, Jane wave lesions. Lovely, and that's how you distinguish. So you've got your C's and you've got your P's, and that is the cardiovascular hand exam. Let's move from the hand, more proximally, let's go to the wrist now. So we have rate, rhythm, character, and volume. So rate should be 60 to 100. Normally 50 to 90 is the mean. Rhythm, is it regular or not? For character, is there a slow rise indicating it's difficult for that left ventricle to empty, such as a stenosed aortic orifice? Or is it bounding because of aortic regurgitation? Is it thready to indicate decreased volume? Maybe your patient is becoming shocked. and then the actual volume itself speaks for itself, right? So rate and rhythm at the radial, character volume at the brachial or at the carotids. You're going to assess radial delay by feeling that radial artery at the same time. And if there's radial delay, you could think that there's an SCA stenosis or aortic dissection. Subclavian artery stenosis, that is. And then on the other side here, what we have is collapsing pulse. Always say to the patient, any pain in your shoulder? Okay, I'm going to elevate your arm quite swiftly. Are you okay with that? 3, 2, 1. Here we go. So for the collapsing pulse, think aortic regurgitation because the left ventricle empties, but then the valves don't close, so the blood flow drops back into the heart. Or think a high output of the heart. It's like constantly going woof, woof, woof. So think pregnancy, anemia, or any kind of infection. Now, when we think about the face, break it down into 3 areas. We've got the eyes, the mouth, and then onto the neck. So move contiguously so you don't miss stuff. So eyes, we're looking for pallor of the conjunctiva, indicative of anemia, xanthelasma, and corneal arcus. Students always get pallor, great, but quite often the corneal arcus is missed, I've noticed. When it comes to the mouth, we're thinking about central cyanosis, which you can see on the tongue, but have them lift the tongue to the roof of their mouth so you can see the venous plexus underneath. Normal dentition, angular stomatitis, and an arched palate. All of these things are leading you to think this patient might have something going on with their cardiovascular system. So in terms of assessing the JVP, this is a video by James Gill. I won't play it for copyright reasons. James Gill was one of my professors at Warwick Medical School. He does a really good thing, so if you just Google James Gill JVP, then you'll be able to see this. But if someone says, what are some of the causes of a raised JVP, you can use JVP. So jammed SVC, so SVC blockage. V, volume up, so overload, i.e. in heart failure. And then pericardial issues, so tamponade or constrictive pericarditis is going to lead to an elevated JVP. So, if we move on to the general exam now, well, we've done the general exam, let's move on to inspection. So look at the 3 S's for inspection. I'm looking for any scars, any structural changes, and if I can see the apex beat pounding away. The scars I'm going to mention are your sternotomy in the midline, thoracotomy to the side, clavicular up top, and the mid-axillary scars. I'll explain what I mean in a minute. Pectus is excavatum or carinatum. We'll come to that. And then the apex is throbbing because of volume or pressure overloads. So, the sternotomy scar, right down the midline there. Okay? Then you've got the thoracotomy scar, which is this anterolateral scar. Oh, I can't get my mouse up, never mind. Let me try and get a laser pointer. Just bear with me for a second. Laser pointer. Yeah, so we've got our midline sternotomy scar here. We've got our anterolateral thoracotomy scar. Mid-axillary scars are going to be developing because of chest drains and things like that. And then pacemaker scars. So often, because of worry about brachial plexus injury, we insert the pacemaker below the clavicle on the non-dominant side. So this patient having a left-sided pacemaker scar is probably right-handed. But always check the other side as well. And ask the patient, do you have a pacemaker? Now, in terms of pectus, so chest excavatum, has it been excavated out, or carinatum, or pigeon chest? Carina is shield, like a big shield sticking out protecting you. So, we've done inspection, now we move on to palpation. Palpation, you're palpating for heaves, and heaves are the pericardium precordium rather, that's a typo. Precordium palpated with the hands. Thrills is a more subtle vibration, so you turn the hands onto their side, and then you feel the apex beat, 5th intercostal space, midclavicular line. For auscultation, your surface anatomy is really important. Aortic, pulmonary, tricuspid, and mitral. Make sure you know the surface anatomy. So 2nd intercostal space, parasternal, on the right-hand side is the aortic. Same, but on the left-hand side is pulmonary. Move it down to the 4th is tricuspid. And then mitral or bicuspid valve is at the apex. 5th intercostal space, midclavicular line, left-hand side. Move up to the carotids, up here, 4, accentuating the positive. So carotid, hold the breath in, otherwise all you'll be hearing is the trach for aortic stenosis. Aortic regurg, move it parasternally down there in the aortic region, sit them forward, big breath in and hold on your expiration. That's aortic regurg. If you move to the axilla and listen with the diaphragm, the big end, you'll hear mitral regurg, and the smaller side is for stenosis. So mitral stenosis, so just flip the bell. So make sure you're doing all those 3 maneuvers, and you can do them in one fluid movement once you finish listening to the valves, and the examiner will be incredibly impressed and give you full marks. So then listen to the back for coarse crackles of pulmonary edema. Classic. And then to complete your exam, as we said, lung bases, you'll tap for sacral edema, you'll tap for pretibial edema, seeing if it's pitting or not, and then you'll check those lower limb pulses. Go distally first of all, so dorsalis pedis between first and second digit, posterior tibial by the medial malleolus, and then move more proximally to the popliteal if you've got any problems. That's the cardiovascular exam in a nutshell. Thank you very much.